Well, I'd like to welcome everybody to this SSR Resident Education Club webinar. I'm very excited about today's topic, which is going to be interesting hip cases. I'll be the moderator for this session, and we are using the poll everywhere. So in order to participate, please scan the QR code that you can see at the upper right part of your screen. If as we go along you have questions, please enter them in the area at the bottom of your screen that says Q&A, and we'll probably address those all at the end. So we're very lucky tonight to have our speaker, and it's my pleasure to introduce her. That's Dr. Sarah Kamel. She did all of her training at Thomas Jefferson University in Philadelphia and is currently assistant professor there in the Division of Musculoskeletal Radiology. She's an expert on MRI, CT, and ultrasound, with an emphasis on ultrasound-guided interventions in the musculoskeletal system. Her research interests includes health economics, especially utilization and cost effectiveness of different imaging pathways for joint pain. Clinically, she's interested in assessing patient outcomes following minimal invasive and percutaneous image-guided procedures, and she'll be speaking with us tonight on interesting hip cases. So without further ado, here's Dr. Kamel.
Thank you for the introduction. So the goal of today's talk will be to familiarize yourself with various hip joint pathologies that come up not infrequently and can be more challenging to work through rather than routine osteoarthritis and degenerative change cases. The goal is to be able to differentiate among conditions with similar presentations in order to provide a differential. And we'll start with osseous and intra-articular pathology, and then a few cases on extra-articular pathology, which can present as hip and groin pain. So starting with poll everywhere, case number 1, this is a 60-year-old male runner. What is your diagnosis? All right. Looks like most people said D, are avascular necrosis with articular surface collapse, which is the correct answer. So this was a great case of a 60-year-old male runner. We have an initial image from 2022 on the left, where you could start to see a geographic area of subchondral lucency along the femoral articular surface, and even a step off at the articular surface showing some articular surface collapse. That's all superimposed on some background subchondral sclerosis. Unfortunately, he continued to run, and his findings progress. A year later, there's marked interval progression with more of the articular surface involved, further degree of lucency, more articular surface collapse, and even a loose body here along the superior joint line. And this is all typical for avascular necrosis, and we'll go into more about that. So the femoral head is the most vulnerable site for development of AVN. The primary blood supply of the hip is from the medial and lateral circumflex arteries. And then there's a watershed zone along the lateral femoral neck, which is also really susceptible to mechanical stress, especially with hip flexion. So the theory is that with repetitive hip flexion and microtrauma, this could inflict some significant vascular compromise, leading to avascular necrosis. Trauma could also cause AVN. Corticosteroid use has been associated with it, sickle cell disease, alcoholism. Sometimes we don't always know the cause, as we did in this patient who didn't have any of the risk factors, just maybe repetitive microtrauma from running for decades of life. On radiographs initially, they will appear normal. MRI is the most sensitive and specific in detecting this, but eventually you'll start to see some subchondral sclerosis and cystic change. Once we start to see the subchondral lucency, which is referred to as the crescent sign, that's a linear cleft in the subchondral bone. That's usually suggesting that there's a subchondral fracture and that articular surface collapse is impending. And then stage 4 appearance on radiographs is when there's secondary degenerative change. So you can see over here now that there's joint space narrowing, there's subchondral cystic change on both sides of the joint in the acetabulum up here. and some marginal spurring in addition to the articular surface flattening. So there's secondary osteoarthritis in the setting of end-stage AVN. Just a couple more pictures of the crescent sign. It's something you certainly don't want to miss. Again, it refers to a linear cleft in the subchondral bone, which is indicative of a fracture. And again, it can propagate and lead to articular surface collapse. So both of these cases, you can see the thin lucency of the crescent sign in the subchondral bone superimposed on the background sclerosis, which is indicative of AVN. On MRI, again, MRI is most sensitive and specific and accurate in detecting AVN versus radiographs, CT, or bone scan. And the most pathognomonic finding is the double line sign on T2 weighted sequences. And this basically represents the sclerotic line of necrotic bone, which is adjacent to a hyperemic line, which represents the interface between necrotic and viable bone, or it's basically like ischemic bone. It's not yet necrotic, but it's just there's granulation tissue and there's some ischemia, but it's not yet necrotic. And that's the characteristic appearance on T2. On T1, there will be a dark line that's crescentic, convex to the articular surface, low signal in the subchondral bone. And again, that represents the interface between necrotic and reparative bone. On MRI, the staging characteristics are basically how much fat is left in the subchondral bone, which suggests which can correspond with the chronology of the disease and how much of the subchondral bone is still viable. So initially, as you can see over here, the subchondral bone, the marrow signal on T1 will be preserved and should be bright on T1 weighted sequences, suggesting that there's still fat within the marrow. Then eventually, when a subchondral fracture occurs, the subacute appearance will be of the presence of hemorrhage and blood within the subchondral bone, and as a result, the T2 signal will increase. Eventually, if there's enough inflammation, the fat content will continue to decrease, and that's where you get stage C, where it becomes more hypointense on T1 weighted sequences. And then finally, if fibrosis and sclerosis predominate, then the subchondral bone will be dark on all sequences. And that's usually when there's less vascularity of the subchondral bone and maybe beyond conservative measures. Post-contrast imaging can also be helpful to delineate if there's a devascularized region. So for example, in this case on T1 coronal and sagittal sequences through the femoral head, you can see that there's a large area where the bone is very dark and not enhancing, surrounded by the enhancing granulation tissue here at the interface between necrotic and viable bone. And this is helpful to the surgeon to know how much of the articular surface is pretty much too far gone. There are lots of different classification systems out there for AVN. We don't particularly follow a certain one. Maybe surgeons in different locations have different preferences. We primarily focus on just describing the findings. So we'll describe the location of the AVN and extent of involvement in terms of percentage of the articular surface. So for example, small lesions that are along the medial anterior superior femoral head may be more amenable to conservative therapy since there's more collateral blood flow. We'll describe if the lesion contacts the subchondral margins. Usually the prognosis is better if it doesn't. And then larger lesions in particular, are more prone to articular surface collapse. So it's important to express that in your report to kind of give a sense of prognosis. If there is articular surface flattening or collapse, you can describe the degree, how much it's depressed. And then finally, bone marrow edema usually correlates with pain. So we'll usually give a good description of how extensive and severe the bone marrow edema is. So this is the next case, a 35-year-old female runner with hip pain. Where is the acute abnormality? This is a touchscreen question. Yeah, maybe about 10 more seconds. So the distribution of these answer choices does reflect the subtlety of this finding and how important it is to look in the specific location. Um, let's see, a lot of you commented on the gluteal enthesopathy out here, which is usually a chronic finding, hydroxyapatite deposition, wear and tear of the gluteal insertions on the greater trochanter. But the most pressing finding in this patient is this callus formation and periosteal reaction along the medial femoral neck, especially in a young female who's a athlete. And this represents a stress fracture. And again, the findings on X-ray are so subtle, but it's almost always the first test that's done. So if you can pick it up, it's a great thing to do. So this represents abnormal stress on a normal bone. Usually we see it in patients with a sudden increase in frequency, intensity, or duration of their physical activity. And in these cases, the repair capacity of bone is outweighed by the microfractures that accumulate. And as a result, a fracture will result. The background bone should be normal. It's not osteopenic. That would be more representative of an insufficiency fracture. This is the same patient who underwent an MRI. You can see on T2 there is a hyperintense signal along the compressive aspect of the right femur, and there's a low T2 signal fracture cleft here, which is perpendicular to the long axis of the femur, which is characteristic of a stress fracture. If these involve less than 50% of the femoral neck, they usually can be managed conservatively. And again, that's because of the orientation of the trabecula and the femoral neck. So with weight bearing, the medial aspect of the femoral neck is under compression and the lateral aspect is under tension. And then there's specifically this Ward triangle here, which is in between the primary and secondary compressive trabecula, which is a site of relative weakness. And that's typically where stress fractures occur, just based on the orientation of the trabecula and where there's relative weakness. Fractures that are located on the other side are rare but can occur. And those usually do not heal well since that bone is continuously under tension. So the fracture will likely propagate. So they have a high risk of fracture progression and AVN, again, because of where the blood supply is the weakest, also on the lateral femoral neck. So those will typically undergo surgery. Another femoral fracture I want to mention are atypical femur fractures, which are usually in the diaphysis along the lateral cortex. Again, this is atypical because this is a site of tensile stress. We typically see these in patients who are on long-standing bisphosphonate use, and bisphosphonates will suppress normal osseous remodeling, and as a result, the bone becomes very brittle and excessively mineralized, and then is more susceptible to the tensile stress along the femur and is susceptible to producing a fracture. Again, the findings can be very subtle, just a little bit of periosteal reaction. If you're lucky in this case, we were able to see a lucent fracture line, and it was also confirmed on MRI. And again, because this aspect of the femur is under high tension, these patients have a high likelihood of fracture progression to completion and will usually undergo intramedullary nail fixation, especially if they have associated pain. All right, next case. This is a 35-year-old female with hip pain. What is your diagnosis? It looks like most people agreed that it looks like transient osteoporosis of the hip with subchondral fracture. We'll talk a little bit more in the upcoming slide of how it's not representative of AVN. And then as far as the other answer choices are concerned, so osteoarthritis, there's no joint space narrowing, there's no subchondral cystic change or really full thickness cartilage loss. So It doesn't look like end-stage OA with subchondral edema, for example. And then as far as osteomyelitis goes, that can always be in your back pocket as a differential, especially with the joint effusion and the marrow edema. But there's no synovitis or synovial proliferation. There's no pericapsular edema. There's no osseous erosion, which would be more definitive signs of infection. And then specifically, there's also a subchondral fracture in this patient, which kind of fits more with transient osteoporosis of the hip, which is right there. So we'll talk a little bit more about this. So basically, in this case, there's intense bone marrow edema all throughout the femoral head and neck, with a small subchondral insufficiency fracture. Transient osteoporosis of the hip is an acute bone marrow edema syndrome. We don't always know the etiology. It can occur late in pregnancy, but there's also been an incidence of it in males ages 40 to 60. It got its name because of the appearance of osteoporosis on the radiograph. Our group recently published a paper on 50 cases of TOH and found that almost all of the cases also had a subchondral fracture. So we're kind of reframing the way we talk about it at our institution, where instead of we're similar to how we used to say spontaneous osteonecrosis of the knee is now known as an insufficiency fracture. We think of transient osteoporosis of the hip as an insufficiency or a fatigue fracture based on the findings of our study published in the Skeletal Radiology Journal. This is a case from that study where this patient was a young female with severe hip pain, found to have marrow edema throughout the femoral head and neck, and then this focal area of subchondral fracture along the articular surface where it's dark on the T1 weighted small field of view or T2 weighted small field of view sequences. Subchondral fracture versus AVN, they do differ histologically. So again, subchondral fracture is not a result of vascular insufficiency or osteonecrosis. So the marrow edema proximally and distal to the fracture lines or the marrow signal should be preserved. Also, the subchondral fracture line is typically irregular. It's convex or parallel to the articular surface, and sometimes discontinuous. So in this case, it's arc-shaped, similar to the surface of the femoral articular surface. And in contrast to AVN or osteonecrosis, that dark line on T1 represents devascularized bone. It should not enhance, and sometimes the proximal superficial bone will also not enhance, like we saw earlier. It's usually a more smooth, continuous hypointense line, and it's typically concave relative to the articular surface. Next case is a 24-year-old male athlete with left hip pain. Where is the abnormality? All right, lots in agreement here. We are looking at a cam-type femoracetabular impingement where there's prominence of the femoral head-neck junction, which you can see on both of these views. So typically, in order for the hip to flex normally, the femoral head needs to be round and there has to be narrowing at the femoral waist. But instead, if the femoral head is aspherical or there's prominence at the head-neck junction, then that will pretty much impact the acetabular rim with all movements involving hip flexion, and it will cause cartilage damage and eventually labral damage. Causes can be idiopathic, can be developmental, traumatic. It could be a result of a childhood condition like Skiffy or Perthes. It could even be iatrogenic after a femoral osteotomy. We see this very frequently. This is another patient who had a CT and MRI. The CT really depicts the bump along the head-neck junction, and then the MRI is great to pretty much show the maceration of the anterior labrum here and some cartilage thinning along the anterior acetabulum, all a result of that impact of the extra bone with hip flexion. Another type of femoracetabular impingement morphology is referred to as pincer morphology, and that's where there is prominence of the acetabular rim, which affects the femur during flexion, especially during internal rotation. And this usually results in labral degeneration first and then cartilage damage. This could be because of overgrowth of the acetabular rim, or it could be because the presence of an os acetabuli, which could focally impact the femur again with hip flexion. So this is a case of a female with a pincer impingement. She had a very large os acetabuli. which you can see here on the radiograph and on the T1 weighted MRI sequence. And in this case as well, there was some marrow edema within the os acetabulum, which was causing her pain as a result of the pseudoarthrosis formed between the acetabulum and the os. How do we diagnose these? The most popular measurements are the alpha angle for cam type impingement. That's where we draw a circle of best fit around the femoral head on axial, and then a line bisecting the femoral neck, and then the angle is drawn to where the femoral head departs the normal spherical outline, and then values greater than 55 are considered abnormal. In this case, it's probably closer to 60 or 70. And then on the AP view, we can use the lateral center edge angle to measure for pincer. Basically, again, we draw a circle of best fit around the femoral head, and then a vertical line, and then the angle is drawn to where the edge of the acetabulum is over covering the femur, and values greater than 39 degrees are considered abnormal. In this case, it's very high, around 65 degrees. Next question, there's a 31-year-old male with 6 months of right hip and thigh pain. And it looks like there's no debate that it's an osteoid osteoma. So this is an MRI through the femur here, where you can see that there's non-aggressive periosteal reaction along the tensile aspect of the femur. There's associated marrow edema, periosteal edema. There's no discrete fraction line. And again, we see a small cortically based lesion with a central nidus that's causing all of this inflammation in the surrounding bone. This is very typical for an osteoid osteoma. Usually we like to see it on CT as well, where you can really appreciate the fine detail of the central nidus in the scan. This was biopsied and also cryoablated, and the patients almost always do great afterwards. Osteoid osteoma is a benign bone tumor. It's typically spherical and very small, diameter of 1.5 centimeters or less. The central nidus represents some atypical bone, which is completely enclosed within a well-vascularized stroma. High vascularity in the peripheral nerve fibers are associated with the significant pain you typically see with an osteoid osteoma, which is relieved by NSAIDs. And about a quarter of them occur in the proximal femur, and they're most commonly cortical in location. We see these not infrequently. This is another case we had recently of a biopsy-proven osteoid osteoma. Even we didn't really see the central nidus on CT, but biopsy did confirm it was an osteoid osteoma in the cortex there, with some marrow edema seen on the MRI. The biggest mimicker for osteoid osteoma is a Brody abscess. That's because both lesions occur in young patients, occur in long bones, have a lot of sclerotic reaction, and both of them have a central lucency with an area of mineralization, which would either represent the nidus in the osteoid osteoma or the sequestrum in the Brody abscess. Lab findings may not always be helpful. A key finding may be that Brody abscess should have regular margins, and the sequestrum should also be irregular and eccentric. So we also had a case of this recently where this was thought to maybe be an osteoid osteoma, but in hindsight, maybe it was quite a little bit larger than standard, slightly irregular margins. This is in the distal radius or the mid radius. After this was biopsied, the pain got significantly worse, and then the MRI did show all that significant soft tissue edema, and maybe some of the periosteal reaction is actually a little bit more aggressive than we saw with the other case that we had. The pathology did end up showing some inflammatory cells and neutrophils and suspected infection as well. And eventually the radiographic appearance changed significantly. So above, that was the initial presentation where you can see the area of lucency and possibly the central nidus right there, but then the lucency did progress, become more expansile, and this was eventually treated as infection. So all of those features would be more atypical for osteoid osteoma. Next case, this is a 20-year-old female with left hip pain. What is your diagnosis? For the sake of time, I'm just going to keep going. Looks like most people guess PVNS. So again, young female, we have, so just to differentiate from some of the other options, OA, there's no joint space narrowing. It's not RA because there's no axial migration of the hip with concentric joint space narrowing. Lytic lesions are always possible, but again, this is a young patient, seems unlikely. This is a typical appearance of PVNS. PVNS is a hypertrophic synovial process with pigmentation from hemosiderin. It can erode into both sides of the joint without affecting the joint space, which is the hallmark. The interarticular form usually happens in the knee, but can happen in the hip, which we saw in this case. The appearance on radiographs, again, what's typical is that you have extrinsic erosion of bone, but the joint space is preserved and there's normal bony mineralization. And then the absence of periarticular calcification, and all of those features can help differentiate it from other inflammatory pathologies. On MRI, this is where you kind of can cinch the diagnosis. The synovium should be low on all pulse sequences because the hemosiderin causes T2 shortening, especially if you have a gradient echo image. Blooming of the hemosiderin is pathognomonic for PVNS. It's important to differentiate it from hemophilia, which can also have the blooming on gradient echo imaging, but typically clinical history can help differentiate that easily. Most patients will undergo a surgical resection with complete synovectomy, but the recurrence rate can still be pretty high. Radiotherapy can also be used to eradicate some additional disease and minimize the chance of recurrence, especially if the procedure is done arthroscopically. But in this case, this patient had to have a total hip replacement to get all of the disease, which was pretty extensive. All right, 18-year-old female ice hockey player with groin pain after a fall. What is your diagnosis? All right, so there is some iliopsoas pathology. This is iliopsoas bursitis. If there was rupture, I'd probably show it to you in a different view, where you'd see some retraction or a fluid gap of the tendon. But one of the iliopsoas bursa is one of the largest bursas in the hip. This patient was an ice hockey player who had an iliacus strain that you could see on the right here, which resulted in an iliopsoas bursitis, which was very symptomatic for her. This is a much more severe case to help kind of delineate the anatomy a little bit better, but the iliopsoas bursa is deep to the musculotendinous portion of the iliopsoas muscle, anterior to the hip joint. So sometimes it can be mistaken for a paralabral cyst. In a small percentage of cases, maybe about 15%, it will communicate with the hip joint, so it could be a secondary sign of hip pathology or a primary sign of iliopsoas pathology. This was a very severe case where this patient presented with a palpable mass. They were worried for malignancy. They got a post-contrast MRI, which just showed that this was all bursal fluid without enhancement, but you could see how it's really compressing the femoral vessels there, and he was having a lot of lower extremity swelling. That was very concerning to him and his provider. This patient was aspirated, and we excluded any infectious or inflammatory etiologies of his pain, and it was finally determined that it was most likely secondary to osteoarthritis of the hip, which was pretty moderate. You can see here, and there's a good sized hip joint effusion, which I guess was just dissecting into the iliopsoas bursa. But he did well with treatment of his osteoarthritis. But this can be a common cause of groin pain and without really a clear etiology, especially if they feel a palpable lump. This is our last case. This is a 30-year-old male with pain after a hockey injury. What's your diagnosis? So yes, it is a core muscle injury. This is a adductor avulsion injury. And we'll talk a little bit about the core. This is the sagittal view of the tear and the coronal view, where you can see, actually, sorry, this is the axial oblique, where you can see the separation of the adductor tendon from the pubic tubercle here with a large fluid gap. The core muscle anatomy is very complex, but to summarize it simply, basically the rectus abdominis and the adductor longus blend together over the pubic tubercle in this broad elongated attachment. They don't directly oppose each other, but they work in symphony together. The rectus abdominis pulls on the pubic symphysis posterior superiorly, and the adductors provide an anterior-inferior force, and together they allow for the motion that you have at the trunk and with adduction of your legs. Um, the biggest issue is that once there's any imbalance in these forces, then you're more susceptible to a core injury, and the imbalance could be caused by hip pathology, knee pathology, scoliosis, a leg length discrepancy, anything really can cause an imbalance, which can make you susceptible to a core muscle injury. These core muscle injuries are much more common in males than females, and are common with sports that with rapid change in direction, twisting, or kicking. Uh, so a lot of the work relating to the core muscle anatomy was done at our institution with cadaveric dissections. One of the surgeons who performs a lot of operations on these patients, we wrote a textbook about this, and his favorite story to tell is how when he was performing a dissection and incised the rectus abdominis in a cadaver, he had his med student place her finger under the pubic tubercle, and once he incised the rectus abdominis, it pinched the adductor longus pinched her finger against the pubic tubercle so severely that she cried. And here's her tear in this schematic here. They've also done more formal studies with manometers showing severe pressure changes in the adductor compartment after incising the rectus abdominis. And this is what the dissection looked like. You can see the rectus abdominis muscle fibers and the adductor longus here forming this broad attachment on the pubic symphysis. But basically, a lot of force goes through the pubic symphysis, and any sort of imbalance will really make you prone to injury in this area. So normal view of the pubic plate and sagittal, you see the rectus abdominis fibers blending with the adductor longus fibers over the pubic symphysis, and you can see that well on MRI here. And there's a thought that an incipient breach has to occur first before more severe injury occurs. And typically that will be along that aponeurotic plate where those fibers blend. So you can see just to the right of midline where the incipient breach is on this side, versus on the other side, it's still normally adherent to the pubic symphysis. So we do a lot of imaging to look for these early tears before such a high grade rupture would occur. The incipient breach can also be along the lateral edge of the pubic plate, where you can start to see a small defect here. You can see the subtle asymmetry along the lateral edge of the plate, along the pubic tubercle where there's some separation and edema there. And that's how these injuries start before they progress to be more severe. There is such a wide spectrum of injuries that can occur of the core, but we'll just review quickly some of the more common ones. So in this case, you can see the normal on the right, and then the patient presenting with pain has severe bone marrow edema, which represents an overuse osseous stress response due to repetitive trauma known as osteitis pubis. But you can see that the pubic plate is still intact, but this can sometimes be the first sign of injury. In this case, we also saw earlier, the lateral edge of the pubic plate is torn from the pubic tubercle, and you can compare this to the normal contralateral side or just a normal image here on the right. Sometimes you can have bilateral injuries. So in this patient, you have a continuous line separation of the pubic plate from the pubic tubercle, and then marrow edema is just on one side. It's important to identify when injuries are on both sides because, for example, this patient is probably only symptomatic on one side because the bone marrow edema is only present on one side. But if the other side is not repaired at the same time, the likelihood of having a contralateral injury from the unrepaired side is very high. So we're always very careful to report the extent of injury. You can also have a midline pubic plate defect with a secondary cleft, or basically a curvilinear cleft going off to one side, propagating the injury versus at the lateral edge, like the prior cases we saw. Here's another case of a secondary cleft where you have a midline pubic plate defect, and then the edema curvilinearly shaped heading towards the right. That's a secondary cleft is what we call it. There are some secondary signs of core muscle injury. For example, of the rectus abdominis muscle, you can see some subtle atrophy on the right versus the left, which can indicate some weakness in the core. And then finally, again, these signs you just don't want to miss because, and especially in some of the high-level athletes, it can progress to a total adductor avulsion like we saw in this case. All right, that's all I had for today. We're happy to take any questions.
Well, Sarah, thank you so much for really beautiful examples and very clear explanations. If anyone has questions, you can go ahead and type them in the Q&A panel. I'll start. There was a question about terminology for is osteonecrosis or avascular necrosis the preferred term, or are they synonymous, and how do you use them?
That's a great question. I think there's still some debate in the literature as well. Um, Typically, we'll just kind of describe the findings, especially with the MRI characteristics in terms of how much of the bone marrow is preserved versus how much of it looks avascular or necrotic. Um, but I think commonly people use them interchangeably.
Yeah, I think in my practice, as long as it involves the articular surface, either osteonecrosis or avascular necrosis, if it's somewhere inside the bone, we just call them bone infarcts if they're not at the articular surface. And you mentioned how important it is for prognosticating the size of the lesion. In your practice, do you actually give an estimate of the measurement of how much is involved, or just small, medium, large?
We usually try and give a percentage of involvement as much as possible, just to give them more of a sense of how extensive it is and compare it to before.
I think that makes sense, and certainly once it's collapsed, game over. But in those cases, sometimes given a measurement on the involvement of the other side, maybe will affect what they do about it. You showed a nice example where you actually gave contrast, and the necrotic fragment obviously doesn't enhance. Is that part of your routine, or typically if it's rule out EVN, you don't use contrast?
No, it's definitely not part of our routine. It was a specific request where I think the patient was kind of on the fence if they wanted a surgery or not, and they kind of wanted to suggest to the patient that yes, maybe it is indicated. It's not, it's too far gone.
Yeah, no, I think most places would say the same, that it's really not necessary to give IV contrast. So it is a nice example. For
Mhm.
for those stress fractures you showed, the one along the medial surface of the femoral neck, there's a lot of times we see someone with a good history. They have, let's say, marrow edema, either linear or sort of dome shaped along that medial cortex, maybe a little bit of periosteal edema on the other side. We don't see that black fracture line. How do you describe those? And what do you tell the surgeons in those cases?
I think usually we'll go by how focal the marrow edema is and how characteristic it is in location. I think we also tend to err more on making it seem more aggressive so that the patient will rest. Because a lot of these patients will continue running and it won't get better. Um, so, if we can see anything we can make out as a little linear line, we'll go ahead and call it.
I actually think for the patient's sake, that makes a lot of sense. I see a lot of people throw out terms like, well, it's a stress reaction and all that. And I've adopted the term, it's just a stress fracture without development of a fracture line. In other words, you got there early enough, but it's in trouble. And in fact, when I call the docs, especially if they're not an orthopedist, if they're just, a medicine doctor or something, I emphasize the word fracture, not the word stress, because you want them really to stop running, especially in a critical place like the tibia or the femoral neck. So I think that's very wise how you do it. Um, you showed in an osteocetabulum, big one. Do you think those are the same as what some of the surgeons call a rim fracture, or do you think it doesn't matter? Once you have that, it's extra bone out there.
I guess it could have started as that a long time ago.
Yeah,
The case
yeah,
I
I
showed
don't
didn't
know
have
either,
a
frankly.
reciprocal marrow, yeah.
Yeah, I know a lot of our surgeons will use that term rim fracture to mean that, and I don't have any way either of telling how it started, but I agree with you. It's certainly an important finding. Do you guys use radial imaging on either CT or MR for FAI, either to look at the labrum or to give a alpha angle?
We don't, we just usually will get the done view on the radiographs to more accurately measure it.
Okay, okay. Um, that those osteoma cases and Brody's abscess were really impressive. Do you think it's the soft tissue edema that's your biggest clue, which obviously you don't have if you do CT, but if you have an MR, a lot more soft tissue edema with a Brody's abscess than with an osteoid
I
osteoma?
think so, and then also how elongated it was. like typically, I guess it should be more spherical and very, very small, but he had no other clinical features to push us into thinking infection over osteoid osteoma, which is why it was biopsied. Um, but it did progress. It got much worse
Yeah.
after the biopsy, which was
Yeah, and like you said, they can have even a high SED rate sometimes, so that's not always clear.
right.
In my experience, if you really tease out that history of night pain, fixed with aspirin, you usually don't get that with Brody's abscess. They usually
Right.
hurt all the time, and the aspirin doesn't really help it. But that's not I don't think a necessary thing. And one final question: the Iliopsoas bursa, both the small and the large one you saw, both had that sort of bilobed shape where it surrounded the tendon. Do you find that to be a useful finding, to say it's not, say, a labral cyst or something like that? Do you find most of them are that
Yeah, definitely
bilobe
the
shape?
way it kind of encircles not encircles, but just forms a U around the iliopsoas tendon, I think is pretty characteristic, especially when you're trying to differentiate it from a paralabral cyst, which is probably the most likely mimicker or other cyst in that region.
Sure. All right. I don't see any other questions in the Q&A. Everyone who's listening, thank you so much. Make sure you tell your friends that this will be recorded. So if they want to watch it later, that's great. And you're going to see there's a survey that will appear in your chat. And we'd like you to click on that link at some point, fill it out, and give us some feedback. I'd also like to mention that the next of these webinars will be on March 13th at the same time, and that will be on interesting hardware cases presented by Dr. Iman Karamian. So again, thank you to everyone. Thank you to Sarah, and have a pleasant evening.